Introduce myself. My name is Corisha. I am the physician liaison here at Pediatric Specialists of Virginia, and you all are joining us for Afternoon with a Specialist. We have Dr. Casella here. We're here today, and I'm super excited you're able to join us, Dr. Casella. It is going to an amazing talk. We will save all questions until the end because we want to make sure everyone gets heard. So if you can't remember, feel free to put it in the chat, and then I'll make sure to circle back when we're finished. So Dr. Casella, take it away.
Thank you so much. It's nice to meet all of you virtually, and hopefully we'll get to do it in person at some time, but it's always great to put a face with the names that I see on notes and referrals. So thanks again. Dr. Pohl is also in the audience. So when I say something wrong, he will promptly step in and correct me. So rest assured, you'll be getting good information. But what I really wanted to take this opportunity was to talk about the imaging that we recommend after a child has pyelonephritis and center around the workup of a UTI and kind of where we stand as urologists and what our thinking is. We see so many patients with UTIs. It's a common diagnosis and it's still a point of contention, I think, sometimes in terms of what we think is the best management strategy for these kids. So what I want to do is a little bit of a whirlwind tour of UTI, the workup, talk about renal scar formation, why we worry about it, talk some about reflux, and then really make some time for us to talk about the workup of the febrile UTI and kind of where we think that that we're going with this and what we recommend as urologists. And then ultimately, a little bit about the management of how we're going to take care of patients with vesicoureteral reflux. So just to get some definitions out of the way, really broadly, a urinary tract infection definition is a pathogenic bacteria or fungus in the urinary system. For us and in the guidelines, a significant bacteriuria is greater than 100,000 colony-form units on a clean catch specimen, or 50,000 or greater on a catheterized specimen, and then any growth on a suprapubic aspiration. You'll hear lots of different classifications, and quite honestly, there's no one standard which everyone goes by, but you'll hear complicated, recurrent, febrile. And really for us, what we become most worried about or most concerned about is when we hear about a febrile urinary tract infection. And technically that fever is greater than 100.4. But when I'm often talking to families about this or talking to other providers, families often ask me, how do I know if my kid's having a febrile urinary tract infection? And my answer is that it is often not subtle, meaning that kids are often sick. They have fevers much higher than this, 101, 102, often doesn't respond to antipyretics. And it's not a subtle finding that we miss when you have a true case of pyelonephritis. So who should be tested for a UTI? Well, I think a lot of us have our clinical suspicions that we go off of. If there's a child that you're a little bit worried about or someone that you're like, man, I don't know if we should catheterize or what we think we should do, there are calculators that are available on the web, and we'll share these slides afterwards, but you could follow this link to the calculator out of Pittsburgh. But using clinical features and characteristics, at least of a urinalysis, you can predict the probability that you're going to have a pathogenic culture. And so may help you make a decision if there's someone that's a little bit on the border. But so people have looked at this. So a point that I want to take a little time about is the collection of the urine culture is incredibly important. Suprapubic aspiration or sterile catheterization is really the gold standard. I don't think anyone's doing suprapubic aspirations anymore. So really our recommendation is for urethral catheterizations if you're worried that the child really has a febrile urinary tract infection. And the reason behind this is that all of the perineum is colonized with pathogenic E. coli or pathogenic Klebsiella. And so it becomes really hard to interpret culture results if they're contaminated or obtained by a clean catch specimen, particularly if you get a couple of organisms there. And the last but not least is that bag specimens are only helpful really if they're negative. I understand that sometimes it's just that's the option of last resort, but it really kind of clouds the picture when we're trying to unparse everything. And to this point too, is that I recognize in busy clinics or you guys may not have catheterizations, abilities or things like that. And if there's a child that needs a cath specimen, at least during working hours, that's something that we have nurses at our clinic in Fairfax or places like that. So we're happy to help coordinate getting a real culture if we're worried about a kid, particularly someone that we know has reflux already or things along those lines. So always happy to help in that regard. So where we're going to kind of focus this talk on going forward from here is that, as everyone knows, in 2011 and then recently reaffirmed in 2021, we came out with the urinary tract guidelines from Pediatrics. And really the take-home message of this was that a VCUG was not recommended after the first febrile urinary tract infection if the child had a normal renal ultrasound. And this was for children between 2 and 24 months of age. And really the reasoning behind this, and I directly quoted from the guideline, was that they believe that the data from the most recent studies did not support the use of antimicrobial prophylaxis to prevent future cases of pyelonephritis. And so therefore, the thought is that if we're not going to give prophylactic antibiotics to help prevent recurrent urinary tract infections, then it's not important to know if a patient has reflux or not, because you're not going to treat them any differently. And so what I want to do in the next part of this talk is really kind of go through a little bit about reflux and why we as urologists believe that, at least in children with high-grade reflux, there is solid evidence that prophylactic antibiotics reduce the risk of future urinary tract infections and subsequently reduce the risk of renal scarring. And therefore, it really is important to understand whether a child has vesicoureteral reflux at the time of the first episode of pyelonephritis. So with that kind of groundwork, we're going to launch in the next part of the talk, but please feel free to interrupt me if there's something that's confusing or doesn't make sense or questions pop up. So for the etiology of vesicoureteral reflux, on the left here, you can see that the most common reason for reflux, sorry, I'm just grabbing my, so the most common reason for reflux is either a short tunnel through the detrusor wall, meaning that the ureter goes through a small amount of detrusor. So as that bladder fills, it doesn't get compressed against the posterior wall of the bladder, and you have urine that goes back from the bladder back up to the kidneys. There's other reasons for reflux, but we're going to focus on the most common being this. And you can see here in a normal ureter, it extends through the bladder wall. You have enough of a compressive of detrusor posteriorly, so you prevent the reflux of urine. If you were to get a VCUG, the radiologist and us grade the reflux based on the level of the reflux and the degree of dilation of the ureter growing from grade 1 to grade 5. And the reason why grading that initial reflux is important is that the grade really predicts the rate of resolution of reflux. So you can see here on the left that if you have grade 1 reflux, your rate of resolution over the course of your first 5 years of life, assuming that you're diagnosing this in a newborn, is pretty good, meaning that at that 5-year mark, there's really only 5 or 10% of kids left with that. Now, the rates of resolution continue to decrease as the severity of reflux increases, or at least the grade does, and then also adding unilateral versus bilateral. There's also calculators available from a couple different sources that we're happy to provide you with so that you can give families a little bit better of idea of, well, now that we know they have reflux, what's the chance of reflux going away on its own? Our thinking around reflux has changed in the past several years, meaning that we now worry about reflux as it's related to urinary tract infections, meaning that if you have low-grade reflux and you're not having urinary tract infections and you're voiding normally, then that reflux is not pathologic and it's not something we're going to treat or follow. So when I counsel families that in a young child that's pre-potty training, so let's say a 1-year-old, if they have low grade or say grade 3 reflux, the way that we usually treat them is we would leave them on prophylactic antibiotics. repeat of VCUG about 18 months from when we made the initial diagnosis. And then if they still had reflux, we would continue them on antibiotic prophylaxis until they're potty trained. But more often than not, once they're over that bump of potty training, if they're no longer having pyelonephritis, we wouldn't recheck to see if the reflux had fully resolved, because as long as they're not having infections, then we're okay. But this is kind of the rates of resolution, and the initial grade is important for framing those discussions with families. So renal scars are the feared complication of pyelonephritis. That's what we worry about, because we know that renal scarring impairs renal function. Believe it or not, reflux nephropathy is still the fourth most common cause for pediatric renal transplantation. There is some evidence too that women with known renal scars have an increased risk of hypertension during pregnancy. And what I'm going to show you in some next evidence is that having a renal scar predisposes you for developing more scars if you are to have recurrent infections. And so ultimately, what our real goal in all of this is preserving as much renal parenchyma as we can and preventing renal scars. So reflux in and of itself is a risk factor for renal scar formation. So on the top here, this was a meta-analysis in 2012, I believe. And so you can see that children with a history of vesicoureteral reflux had a 2.5 times prevalence of renal scars on their initial DMSA scans. If you take out the subset, children with high-grade vesicoureteral reflux, so for us, high-grade is dilating reflux, anything grade 3 and higher, had an additional two times greater risk of renal scars, so almost a 5 times greater chance of having a renal scar when compared to the general population. Now, sometimes this is a little hard to parse out whether this was a scar that was abnormally developed renal tissue or secondary to a urinary tract infection. But nonetheless, we still think that that abnormal area of renal tissue predisposes you to future renal scars, and is important to watch out for and do everything we can to prevent recurrent infections. So what I want to show you in the next part of the talk is really make the case that prophylactic antibiotics prevent urinary tract infections and renal scar formation in children with high-grade reflux. This is a little bit of a distinction from what was made in the initial guidelines, and the subset being that this is really in high-grade reflux, so grade 3 and higher. The guidelines make a distinction for all grades of reflux, but what I'm really focusing in on is the children with high-grade reflux now. So some problems with the initial AUA or with the AAP data that they used to develop those guidelines is the first thing is that the data that they were looking at, specifically some of this earlier data, included a large number of males who were uncircumcised. And the reason why that's problematic is that we know that males who are uncircumcised are at a higher risk of urinary tract infections, regardless if they're on antibiotics or not. And so you can see even some of the most recent trials, the QD trial and then the Swedish reflux trial, had high percentages of the males within the population that were uncircumcised. And that becomes problematic because, at least in current times now and under our management, that if a child comes in with reflux and is a male who is uncircumcised or with pyelonephritis, then we very much strongly recommend a circumcision, because often that's the single greatest thing we can do to reduce their future urinary tract infection risk. The other problem is that if you look back through the historic data that was cited within the AAP guidelines, is that it is often unclear exactly how urine cultures were obtained in these studies. And you can see that in some of these, there was bag studies were the only study that was used, or it wasn't disclosed as to how these urine cultures were obtained. And really, the QD trial and the majority of the Swedish reflux trial and the River trial, which we'll talk about a little bit, were the ones where catheterization was, for most part, the standard that was used. So it's really hard to comment on the outcomes of these prior studies when we didn't have a firm understanding of exactly what the urine cultures were. So for those of you who haven't heard of the Swedish reflux trial, it was randomized controlled trial in children with dilating reflux, so meaning grade 3 or higher. They were set to the treatment arms of either prophylaxis, so antibiotic prophylaxis, endoscopic treatment, which we'll talk a little bit about, which is deflux injections to correct that, or surveillance. And at least the takeaway point was that in children who were placed on prophylaxis had a significantly decreased risk of recurrent febrile urinary tract infections compared to those who underwent endoscopic management initially or surveillance. And so this was a randomized control trial. It was well done. And one of the real ones that shows that there definitely is an improvement with antibiotics with high-grade reflux. The River trial, of course, is the one that we're still talking about. So a double-blind, placebo-controlled study, and it compared daily Bactrim to placebo in children between 2 months and 72 months of age who were diagnosed with vesicoureteral reflux. And it was a enrolled study, meaning 607 children were enrolled over 2 years. And the primary endpoint was the incidence of a recurrent UTI. As we'll talk about, some secondary data came out which confused things a little bit, but still make the point. So in the River study, daily Bactrim reduced the incidence of recurrent pyelonephritis when compared the placebo group and the Bactrim group. So it's a little confusing because they did have a section of patients that didn't have 2-year outcome data. So if you look at the intention to treat analysis, if you assume that those the children that you didn't have data on did not have a urinary tract infection, the difference between the rate of a recurrent urinary tract infection in the placebo group was 25% and 12.5%. Oh, did I lose you guys?
We're here.
Oh, okay. Never mind. Sorry, I lost my pointer. The difference was 12.5% between the treatment and antibiotic group. Basically similar numbers for the, depending on how you look at the intent to treat analysis. So the takeaway from the River trial in terms of antibiotics is, at least in patients, if you looked at all comers with reflux, meaning high-grade and low-grade reflux, that you had about 12% decreased risk of having a recurrent infection if you were treated with antibiotics. The part where the River trial started to get a little confusing was that the renal scarring was used as a secondary outcome. And initially, there was no difference between patients that had been treated with antibiotics and those who had been on the placebo in terms of the incidence of new renal scars that were detected at the end of the study. The goal of the study was that you got a DMSA scan when you enrolled, and then another one at the end of the 2 years. Sorry, guys, my slides froze for a second, so I'm seeing if I can unfreeze them. There we go. Perfect. So the scar formation was a little confusing out of the River trial, because if you looked at the patients who had new renal scars, of which all of these patients, there was 37 who developed new renal scars. But the weird part about it was that new renal scars were detected without evidence of a recurrent urinary tract infection in about 19 of these patients. And so that part didn't have a real explanation, but if you selected out the patients with a recurrent urinary tract infection documented within the study, and that was 18 of them, 13 of those patients were in the placebo group that had new renal scars, and only 5 were in the prophylactic antibiotic group. So there was a significantly decreased risk of new renal scars in patients who had a documented recurrent urinary tract infection when compared between those who are on placebo and those who are in the prophylactic antibiotics. So with these 2 points, or these 2 most recent studies, really urologists at least look to this, that we do have good evidence that treating patients with prophylactic antibiotics reduces the risk of recurrent infections and reduces the rate of new scar formation. And so with that background, we really think it's important to know if a patient has high-grade reflux, because we're going to treat them with antibiotics, because we believe that we have evidence that supports that decision to prevent future problems and prevent scarring. And the next kind of paper that came out in 2015 out of Boston Children's, which I think is maybe one of the most important ones that we're talking about here, was that they took patients who were coming to the institution, and as you can see, there was 2,200 patients included in this study. And on the same day that they had their VCUG done, they had an ultrasound done beforehand. And as you can see, that 75% of the patients had a normal renal ultrasound, but they detected vesicoureteral reflux in about 41% of the same population. And so based on this, ultrasound had a limited sensitivity of 64% and only a specificity of 60% for all grades of vesicoureteral reflux. So if you take this back and go to the initial recommendations of the guidelines, that not obtaining a VCUG and only relying on an ultrasound as your test at the time of a first febrile infection does a very poor job of detecting underlying reflux. If you look at this study came out of Europe, where they had introduced the NICE guidelines, which are more restrictive than the current recommendations. And so the current NICE guidelines are that you only get imaging if you're less than 6 months of age or have a recurrent or atypical infection, or you don't respond to initial 48 hours of antibiotics. And what they did was they applied the NICE guidelines to a cohort of patients who had already been treated as they previously had with a VCUG at the time of initial infection. And you can see that out of 934 patients, originally they knew that about 10% of them had an abnormality on subsequent VCUG imaging. If you look at this 11% of patients, the new guidelines only detected 41% of them. So 44 patients were there. And of those remaining 58% of patients, or 61 patients, 30 of them had significant abnormalities. And the way they defined significant abnormalities was an abnormality that would have changed the treatment course, whether that be recommending medical therapy or surgical intervention. And so it's kind of scary to look at this and say that if we go back to these more restrictive guidelines, we're potentially missing 30 patients out of this cohort that we would have treated differently. And that by waiting for them to have a second infection or more issues, we are potentially putting them at risk for further renal damage or further renal scarring. So with this in mind, what do we as urologists recommend now? Well, we're in agreement that anyone with a febrile urinary tract infection should certainly get a renal bladder ultrasound. And we feel strongly that if you have a real documented case of pyelonephritis, meaning with a catheterized culture of febrile illness, that you should get a VCUG or a DMSA, as I'll talk about in a second, to screen for vesicoureteral reflux. And just to reiterate, our reasoning behind this is that ultrasound really is a poor test to identify reflux. And we have good data that shows that there's a decreased risk of UTIs and new scars in children with high-grade reflux who are treated with antibiotics. There's uniform agreement amongst our group that prophylactic antibiotics are indicated in patients with high-grade reflux. Patients with low-grade reflux, so grade 1 or 2, are optional. But the other part that really comes into this is identification and treatment of bladder and bowel dysfunction. So if you have a child who is a dysfunctional voider, meaning if they're holding their urine or if they're constipated or if they're having accidents or things like that, we know that that in and of itself increases the risk in association with low-grade reflux. So those are often patients that we will often treat with antibiotics in addition. So we certainly take other factors, but with grade 3 or higher, we uniformly recommend antibiotics. In case you hear about it, or as I mentioned before, there's really there's two philosophies in terms of working up or ruling out reflux, which is the bottom-up algorithm, which is how we have traditionally done this, meaning that if you have a febrile UTI, we get a VCUG and a renal ultrasound, and sometimes we will get a DMSA to determine if there is scar tissue there or not within the kidney. The top-down approach is that in a child with a febrile urinary tract infection, you start with a DMSA because, as I'll show you, DMSA is sensitive to high-grade reflux, and we only go to getting the VCUG if we detect renal scarring. And the thought behind this is that we really are, once again, worried about renal scars. That ultimately is what we care about treating. And so we're going to be less aggressive in the management of a child that has normal kidneys without evidence of scarring versus one that does. The issue with the top-down approach is that it is, once again, it's very sensitive and specific for high-grade reflux. It's less sensitive for low-grade reflux. And there was good studies that showed that that if you are one of those patients that gets both the DMSA scan and a VCUG, that the cost associated with that is higher, and you end up with a higher radiation exposure as opposed to the bottom up. So how we're working to change what we do right now and address some of these issues is that we are now doing contrast-enhanced ultrasounds, contrast-enhanced ultrasound VCUGs at Children's National. And if you're not familiar with them, what contrast-enhanced ultrasounds are is that they were originally designed to look at myocardial function, so that they're small, invisible microbubbles that are injected intravenously, or can be, or instilled into the urinary system, and are reflective under ultrasound. And so the way a catheter is still placed for these, but then they fill the bladder with microbubbles, and that's what these orange things are here. This is actually microbubbles within the collecting system of a kidney. And then while doing real-time imaging, so meaning watching while the child is voiding and while the bladder is filled, they're able to see what's going on and see if there's reflux throughout the entirety of the cycle. And so initial studies actually show that the VCUG with contrast microbubbles is actually more sensitive than traditional VCUG, primarily because we're getting continuous imaging. Now, many of us will still get the traditional fluoroscopy VCUG as our first study, mainly because the ultrasound VCUG does not give us a view of the total anatomy, meaning doesn't give us a view of the sacrum, it doesn't give us a view of the bony anatomy of the pelvis, and sometimes has some difficulty visualizing the bladder neck during the voiding phase. But most of us, at least for our follow-up studies, are getting these, and we're working towards using them as our initial study as our techs are getting better at it and being able to provide us with all the information that we need. On the right side of the screen, the other thing that has come out now is that you can use contrast bubbles, which are injected into the collecting system, to perform essentially an ultrasound DMSA scan. So these are sensitive to allow us to identify perfusion defects in the kidney. And right now, we're working at Children's towards establishing a protocol where ideally a patient would be able to come in and in the same setting, same clinical visit, would be able to get a VCUG and a perfusion study of their kidneys, all radiation free and in the same thing, in the same time frame. And so that would really allow us to identify those who have scars, those who are at higher risk, and high-grade reflux, all removing the radiation exposure, which would be a real step forward and help us kind of hone our therapy in for these children. So we're working on this now. The contrast VCUGs we do routinely, and we get those all the time. It's the DMSA part that we're working on incorporating. And then I wanted to take a chance to talk about the surgical management of reflux, because part of this use of antibiotics and things like in the push to not treat reflux surgically has certainly been good, because we've decreased the number of surgeries that we're doing. But that being said, is that we now have other options for treating reflux. As you see here on the left side, this is deflux injection. And so what deflux is essentially a bulking agent that we can inject into the bladder wall. And we do this cystoscopically. So there's no incisions, there's no cuts. It's an outpatient surgery, so they go home the same day, and it's very well tolerated. There's a select patients that we use this for, but when we use it, they do well, and it's a good option. The other option is on the right here. You can see this is an open ureteral reimplantation where we physically reconnect the ureter to the bladder in an anti-refluxing mechanism. But the point I wanted to make about this was that on average, children spend 1 to 2 nights in the hospital after this. And we recently are really pushing to use regional anesthesia. And so I've even done a couple of reimplants under a spinal anesthetic. And so the children have been sedated, but under spinal anesthesia, and not require general anesthesia to do it. And in general, particularly when we do this in younger children who are before potty training, the kids do really well. And the success rate is great, meaning it's about a 97 to 98% success rate of fixing the reflux, and it's taken care of and solved. So I think that, like all things, perhaps the pendulum may have swung a little bit in the other direction. And I'm certainly encountering some parents now who are tired of doing antibiotics or just don't want the uncertainty of not knowing if their child's going to get an infection again, and are opting for surgical management. And so kids do well with it. So we certainly try conservative management, but it's nice to know that we have good treatment options in our back pocket. And the last thing I just wanted to briefly mention was that in addition to antibiotics, some of the research that we're doing in the division and also with nephrology colleagues is looking to see if there's a way that we can augment the use of antibiotics to change the innate immune response, because we know that that is central to scar formation. And ischemia reperfusion injury, or the robust kind of a response to having a bacterial infection, is ultimately what causes scars. And interestingly, there's a novel kind of central nervous system pathway that's vagally mediated that actually suppresses the suppresses the innate immune response. And in some initial animal studies, we actually found that Chantix, which is the drug to stop smoking, actually binds to some of these nicotinic receptors, which ultimately modulates the innate immune response. And in some initial mouse studies, we showed that mice that we gave antibiotics and Chantix to had less scarring when compared to those animals that we treated with antibiotics alone. So early work, but we are still pushing towards other ways that we can give antibiotics and other treatments to help potentially reduce scar formation and long-term renal sequelae from infections. So I'm wrapping up sooner than I thought I wanted to do, but I figured we'd simulate a lot of questions, so I wanted to leave plenty of time for that too. But in conclusion, really, prophylactic antibiotics limit recurrent pyelonephritis in kids with high-grade VUR. We believe in it, and that's why we treat them. And along those lines, we think that everyone should have imaging to assess for VUR if they have a truly documented case of pyelonephritis. New technology is on the horizon, and I hope that with that, we're going to be able to really limit the radiation exposure to kids and to augment our antibiotic therapy. I guess some questions and some asks that I have for you as my colleagues is that one thing that would be wonderful is that if we could streamline getting culture results to us, or at least have a way so that when patients come to our clinic, as you know, lots of times patients, it's wonderful that we're all in Epic and we can share that way, but a lot of times we get patients come in and it's hard for us to tell whether or not they truly had pyelonephritis or how things were diagnosed. And that's really some critical information from our end, because it dictates what we're going to offer as the next step of management and workup. And so we're always available. We have a nurse at Fairfax, and we now have a full-time PA and working on getting a second one. So my hope is that our team is available to you guys. If you have questions or worries about a patient, we're always happy to talk and see how we can best get them taken care of. So thank you, everybody, for your attention, and happy to entertain any questions.
Hi, this is Diana Cluett. Thank you for teaching us and giving us, some review and some new information that I think we all sort of need a little guidance on. Just to clarify, when we have a kid who has pyelo, I know you'd like us to get is it VCUG and ultrasound at the same time, or is the VCUG? Because I know you're sort of taking us down those different pathways. It's both, or just start with the VCUG?
You can, if you have a kid, so I'll take that in two parts. So first off, if you have a kid that has real pyelonephritis, like documented pyelonephritis, no doubt about it, it is safe to get a VCUG within 48 hours of starting antibiotic therapy, as long as they're not febrile anymore. And the test, we would recommend getting both an ultrasound and a VCUG.
Okay, and the time frame on the ultrasound?
Same time. You can usually get it. So whenever they can get in to have it done. The VCUG is really the most important test of both of them, but we would also want the ultrasound just to make sure we're not missing any potential, obstructive problems with the upper tracts or things like that.
Okay, thank you.
Yeah.
Thanks. A tag along to that. This is Trish McDade. I've heard before that we weren't supposed to be getting ultrasounds if they were active, like they come in and they're febrile and we're thinking it's pyelo, but you're saying it's okay to get both at the same time.
Yeah, it is. That you need to have 48 hours of antibiotic therapy before getting the VCUG. But I would suspect in most cases it's probably harder to get, it's probably rare that you're able to get an ultrasound within 48 hours, but it is okay to get the ultrasound at any point. The VCUG, we'd want to wait 48 hours.
Thank you.
Of course.
I'll ask another question then, since it's quiet. I have a question about these kids with these group B strep UTI kind of looking things, and I don't typically treat them, but I didn't know if you felt strongly about those.
I think it's a good question, because certainly we're seeing it sometimes. I think that once again, it comes to us a lot of times, it comes down to whether or not they have a fever. And if they're systemically ill and have a fever, then I think it's worth treating. If they don't, and they're otherwise themselves, or not having a fever or something that's worry from, we don't think they have pyelonephritis, then oftentimes then I look for other risk factors like constipation or poor voiding habits, and really try to encourage, extra hydration and voiding more frequently, and see if we can get away without treating with an antibiotic.
Thank you.
Any other questions?
Sorry, this is Dr. Yu. Quick question. So for the prophylaxis, I saw that for the Bactrim, it was like was it 2 months and up? So if you have someone who's less than 2 months, do you start with amoxicillin or nitro?
Yeah.
Or...
Yeah, we usually start with amoxicillin, and then I give it an extra month. So I wait till they're about 3 months of age before I transition them to Bactrim. And there was a brief window where we were having trouble with an amoxicillin shortage. And in that case, we were using Keflex, but I think that that has now gone away. I haven't heard of anyone having trouble filling the prescriptions lately for amox.
Oh, sorry, one more question. So
Yeah.
sometimes I have kids that grow Proteus, and I guess not necessarily with any specific symptoms, but they're growing. Is that just colonization, or is that something that you have to keep treating?
Yeah, the only thing with Proteus that we do is that so often we will see that in an uncircumcised boy, is where it shows up. If it's in someone who is circumcised or a girl, or recurrent infections, the only thing that we would recommend is getting upper tract imaging, like an ultrasound, just to make sure there's not any worry for a stone, for a kidney stone in association with it.
Okay, so if it's an uncircumcised boy, if they're asymptomatic, then
Yeah.
you don't need to, and you can just sort of leave it alone.
Yeah, I usually, if they're
Okay.
asymptomatic and it's an uncircumcised boy and he's otherwise fine, then no, I don't treat that.
Thank you.
Yeah.
All right, I think that we are all set.